Hello friends, this is Dr. Sushanta Bhanja, author of Self-Assessment and Review of Pediatrics and Neonatology. Today I will discuss the recent pattern INI Super Specialty CET January 2022. And the first question, which of the following is the largest component of the surfactant? So the answer is saturated one. Okay, now the largest component of surfactant, that is saturated phosphatidylcholine, accounts for 50% than the unsaturated, which is 20% only. For the long term memory, that is saturated more than unsaturated. So S comes first than U. So saturated is most common than unsaturated phosphatidylcholine. Now let's discuss. So surfactant replacement therapy, few questions asked. So the surfactant is synthesized by which cell? That is type 2 pneumocyte. Okay, there are two types of cells, type 1 cells and type 2 cells. Okay, now type 1 cells account for the most of the surface area, around 90%, and 10% is type 2 cells. And this type 2 cells secretes the surfactant. Okay, so and the function of the surfactant is that is it reduces the surface tension of the fluid. Okay, so it reduces the surface tension and also increase the functional residual capacity. Okay, now component of surfactant. So the major component is lipids than protein. Clear? Now among the lipid, I have told you the saturated dipalmityl phosphatidylcholine, or it is also known as lecithin, accounts for 50%, and that is most common. So this is most common than unsaturated phosphatidylcholine, it accounts for 20%. Now other than this, the phosphatidylglycerol, neutral lipids, other phospholipid. So next is the surfactant protein involved, 6%. So among the surfactant protein, so A is the most common surfactant protein, then surfactant protein B, then surfactant protein C, and surfactant protein T. Okay, so these are the components. Among these, the most common is saturated, that I have already discussed. Now next question is asked, appearance of surfactant. In the fetal lung, the surfactant appears as 20 weeks of gestation, appear in the amniotic fluid and 28 to 32 weeks, and in the mature level of pulmonary surfactant after 35 weeks. So 3 MCQs, that is fetal lung 20 weeks, amniotic fluid 28 to 30 weeks, and mature level 35 weeks. Okay. Now the commonly used surfactant preparations are natural and new synthetic. Among the natural, the B for bovine, B for baractant, C for cup lung lavage, they were calfactant. So porcine, poractant. So these are the natural surfactant, baractant, calfactant, poractant. So the baractant comes under Bhanja, calfactant Infrasurf, and poractant is Curosurf. Okay. So next, new synthetic surfactant again divided into the second generation and third generation. So new synthetic surfactant, the second generations are lucinactant, cinapultide, and lusupultide, and the third generation is CHF 5633. So these are the synthetic preparations of the surfactant. Now coming to the dosing and interval. So we know the term neonate, the surfactant pool is around 100 mg per kg, and in the preterm neonate only 4 to 5 mg per kg. That's why in respiratory distress in preterm usually give a minimum of 100 mg per kg of surfactant. Okay. Now the repeat dose is 3 dose is recommended. Now what are the indications? Other than the RDS in preterm, respiratory distress syndrome in preterm, there are certain indications like Meconium aspiration syndrome, pneumonia, pulmonary hemorrhage, congenital diaphragmatic hernia, and acute respiratory distress. Okay. Now coming to the surfactant replacement therapy, if the gestational age is more than 28 weeks and respiratory distress at birth, and the requirement of CPAP is 40%, FiO2, then early rescue surfactant within 2 hours is indicated. Or if the child is in respiratory distress and requirement of mechanical ventilation with FiO2 30%, so 40% and 30%, then you can give early rescue surfactant therapy. So this is the question asked in previous AIMS. Okay. Next, continued mechanical ventilation. Now the repeat dose after 4 to 6 hours of initial dose if the FiO2 requirement in CPAP is more than 40%. So after 4 to 6 hours of initial dose, if there is FiO2 requirement is more than 40%, then you can give a repeat surfactant. Now next is any of the following: no or incomplete antenatal steroid, intubation and gestational age less than 26 weeks, then you can give prophylactic surfactant after stabilization of the knee. Okay. Now next is what are the type of surfactant therapy? Prophylactic surfactant therapy, which is given within 15 to 30 minutes and indicated in less than 28 weeks of gestation. Early rescue surfactant therapy, which is given within 2 hours, the inborn preterm with RDS, and after 2 hours usually outborn baby. Okay, so and it is called as late rescue surfactant therapy. And the repeat dose of surfactant maximum 3 dose. So this is a question asked in previous exam. As we know, ACS antenatal corticosteroid usually is 2 dose, but surfactant resuscitation therapy usually 3 dose. Okay, so these are the types of surfactant therapy. Now how to administer is very important. There are the invasive method, that is insure. That means, what do you mean by insure? In means intubate, SUR means surfactant, and E for extubate to CPAP. So insure therapy is the invasive. Next is the minimally invasive therapy, that is mist. Okay, with the catheter like angiocath 16G and without muzzle forceps. Next is the less invasive, that is LISA, and it is given through the feeding tube 4 to 5 furlong catheter, and the trachea used is the forceps, muzzle forceps is used. So L for LISA and L for muzzle. So for the long term memory, many a time question is asked, muzzle forceps is used for LISA. Next, truly non-invasive is nebulized surfactant delivery, and the LMA, laryngeal mask airway, give the surfactant. So these are the administration of surfactant. Clear? Now the side effect of surfactant is airway obstruction, air leak and hemorrhage, pulmonary edema. So airway obstruction leads to hypoxemia, bradycardia and apnea. Air leak leads to pneumothorax, and the pulmonary hemorrhage is most common in natural surfactant than the synthetic surfactant. So this is a very important question. So more common in natural surfactant than the synthetic surfactant. So this is all about the surfactant replacement therapy. Move to the next question. So the next question, the antenatal corticosteroid includes the reduces incidence of RDS and BPD, RDS but not BPD, BPD neither RDS nor BPD. So you know the antenatal corticosteroid reduces the RDS but not the BPD. So this is the answer. Okay. So let's see the antenatal corticosteroid, what are the beneficial effect. So antenatal corticosteroid reduce the neonate is regularly monitored. Neonate means NEC, is means intraventricular hemorrhage, S for neonatal sepsis, R for RDS and mortality. So these are the proven effect that reduces NEC, IVH, sepsis, RDS monitoring. Beneficial effect seen in BPD, PDA and ROP. Okay. So mnemonic is BPR, BPD, PDA and ROP. So these are the less beneficial one. Now coming to the what are the antenatal corticosteroid therapy given to the mother, okay, to prevent the respiratory distress syndrome. There are two. The worldwide the drug of choice is betamethasone sodium phosphate and acetate, and it is given 12 mg IM 24 hour apart. So 2 dose, B for betamethasone, B for bi dose, that is total 2 dose. And the dexamethasone is steroid of choice in India, that is 6 mg IM every 12 hours for 4 dose. And the in ml 6 mg means 1.5 ml, and the 12 mg of betamethasone is 2 ml. Okay. Now coming to the, so In India, the beta-methadone acetate, one is the long-acting and phosphate for fast-acting. Okay, acetate for long-acting and phosphate for fast-acting, which requires only 2 doses of 12-hourly interval, is not available in India. The available salt in India is beta-methadone phosphate, okay, which is short-acting and requires more frequent administration as compared to former. Hence, the dosage schedule of beta-methadone phosphate is similar to that of the dexamethasone and has no added advantage over dexamethasone. Again, the beta-methadone is more costly and less stable. That's why dexamethasone is preferred in India. Okay. So, another important that dexamethasone has a better outcome in reducing intraventricular hemorrhage, not the PVL, paraventricular leukomalacia. The drawback is maternal sepsis is increased due to the dexamethasone therapy. Okay. So, these are the, now what are the indication of ACS and what is the contraindication of ACS? The indication, that is the ACS is given to all pregnant women in 24 to 34 week gestation. Okay. Now, contraindication is chorioamnitis. Okay. The features of chorioamnitis is the development of fever and lower abdominal pain. On examination, there will be foul smelling liquor, foul smelling vaginal discharge, tachycardia and uterine tenderness, and fetal tachycardia. Okay. So, fever, fetal tachycardia and foul smelling vaginal discharge. So, these are the contraindication. Okay. Now, the repeat dose is given maximum 2 doses. Okay. So, these are the questions asked in ACS, antenatal corticosteroids. Now, move to next question. So, which of these are not correctly matched? The infliximab, TNF alpha. So, it is correctly matched. Abatacept T cell activation inhibitor, yes, it is correctly matched. Anakinra, ANA1, that is interleukin 1, it is correctly matched. Tocilizumab, humanized TNF alpha inhibitor, no, this is the interleukin 6 inhibitor. So, the answer will be D. Okay. So, this is very, very important because many times the question is asked from this treatment of rheumatic disease. Okay. There are pharmacological treatment of GRA can be divided into adjuvant drug and disease modifying drug. Okay. So, adjuvant and DMARDs. So, adjuvant drug, that the NSAIDs, okay, and the glucose corticoid and DMARDs are like conventional and biological. So, let us see what are the DMARDs, that is disease modifying anti-rheumatic drugs, non-biological and biological drugs. Now, the non-biological are methotrexate, it is a DMARD of choice. Okay. Now, what are the other drugs, that is leflunomide, sulfasalazine, chloroquine. Okay. And the biological drugs are tumor necrosis factor alpha inhibitor like adalimumab and etanercept, infliximab. Interleukin 1, that is the anakinra. So, the sounds like one canakinumab, okay, cana, and this is a rilonacept. Okay. So, 3 interleukin 1 receptor, that is the anakinra, canakinumab and rilonacept. Okay. Now, next is the interleukin 6 inhibitor, that is tocilizumab. Tocilizumab is a interleukin 6 inhibitor. And monoclonal antibody against B cell, that is the rituximab. And abatacept binds to CD80 and CD86, inhibit T cell activations. Clear? Now, next is the, other than this, other drugs like secukinumab, it is interleukin 17 antagonist, ustekinumab interleukin 23 antagonist, tofacitinib, Janus kinase in 1 and 3 inhibitor, baricitinib. So, B for bi and B for Janus kinase 2 inhibitor, and belimumab is anti-bliss. Okay. So, these are the drugs used in rheumatic diseases. Now, the side effect is very, very common and repeatedly asked questions. So, the naproxen, the side effect is other than pseudoporphyria, this was asked in previous exam, the tinnitus is a side effect of naproxen. Okay. Now, next is the brufen. Ibuprofen, there is a aseptic meningitis like. So, this was also asked in previous exam. Other than ibuprofen, aseptic meningitis is a side effect of, that is IVIG. Okay. The glucocorticoid, you know, the Cushing syndrome, osteoporosis, avascular necrosis. Methotrexate, you know, elevated epilepsy, lymphoproliferative disorders, interstitial pneumonitis, and alopecia. Next is the leflunomide, there will be peripheral neuropathy, alopecia also. Okay. Hydroxychloroquine, retinal toxicity, you know very well, and the QTC prolongation and myopathy. Sulfasalazine is for sulfasalazine Stevens-Johnson syndrome. TNF alpha blockers, the most common side effect is T injection site reaction. So, before therapy, we should TB testing before therapy is recommended. There will be DS antibody positivity will be there, lupus like syndrome will be developed, or leukocytoclastic vasculitis will be developed, and interstitial lung disease and demyelinating syndrome. So, these are the side effects of TNF alpha. Other than this, the abatacept, there will be increased malignancy risk, rituximab, serum sickness, and reactivation of hepatitis B. So, rituximab B for B. Okay. So, B for B, rituximab. Other than this, PML. So, PML and reactivation of hepatitis B, two major side effects. The anti-bleach belimumab, there will be depression is the side effect. Canakinumab, vertigo, headache. Rilonacept leads to dyslipidemia. There are two drugs that leads to dyslipidemia. One is rilonacept, another is tocilizumab. Okay. So, other than dyslipidemia, the tocilizumab, thrombocytopenia is there. Cyclophosphamide leads to hyponatremia, bladder cancers, hemorrhagic cystitis, which is prevented by mesna. Okay. And the mycophenolate mofetil, there will be progressive multifocal leukoencephalopathy. So, PML is a side effect of mycophenolate mofetil and also that is the rituximab. Okay. So, these are the questions. Now, IVI is this is very important: infusion reaction and chills, aseptic meningitis, renal failure, acidosis, and CUM positive hemolytic anemia. Okay. So, these are the side effects of. So, CUM positive hemolytic anemia, rare side effects, but yes, it is side effect of CUM positive hemolytic anemia. Okay. Now, move to the next question. So, which of the following is not a complication of IVIG therapy? Hemolysis, yes. The CUM positive hemolytic anemia. Renal insufficiency, yes. Aseptic meningitis, yes. Thrombocytopenia. So, the answer will be D. Okay. Now, reference is from AHA guideline, okay, on KD 2017 in the guideline. Now, next move to next question. According to Bell staging, which of the following is a feature of NEC2B, not a 2A? Okay. Here, pneumatosis intestinalis, the feature is the staging is 2A, portal venous gas 2B, okay, blood in the stool, if the occult blood positive then 1A, and observed blood is 1B, and abdominal tenderness and dilation. Here the 2B is answer is portal venous gas. Okay. So, as radiological sign, the pneumatosis intestinalis, this is the pneumatosis repeatedly asked question. Air dissecting the bowel wall, it is the hallmark. So, hallmark radiological sign is pneumatosis intestinalis, which is 2A, and the portal venous gas, the severe disease, and this is the pneumoperitoneum of perforation. Okay. So, these are the radiological signs. The staging system is modified, the Bell staging. 1A is suspected. Here the occult blood is positive. Okay. 1 means suspected, and 1A, 1B, the gross blood in the stool is 1B. 2A, there will be radiological sign pneumatosis intestinalis, and treatment will be 7 to 10 days, antibiotics with NPM. And 2B, there will be a triad, that is metabolic acidosis, thrombocytopenia. Okay. So, it is the 2B and portal venous gas, the NPO, and 14 days antibiotic will be there. And 3A, there will be ascites. Okay. And ascites, DIC, neutropenia. Okay. And 3B, there will be pneumoperitoneum, and surgery is the treatment. Okay. So, these are the staging, modified Bell staging. Now, the triads in NEC is very, very important. Okay. The biochemical triad includes the acidosis, platelet will be decreased, sodium will be decreased, hyponatremia, and H plus will be decreased, that is acidosis. Okay. So, this is the biochemical triad. Okay. And the clinical triad is abdominal distension, vomiting, and blood in stool. Okay, so these two triad is very important. Radiological triad we have discussed pneumatosis internally, portal venous gas and pneumoperitoneum. Okay, now coming to the next question. Okay, all statement about seizures are correct when compared to jitteriness except. So, often associated with autonomic changes, fast movement of equal amplitude, have both fast and slow component, yes. Does not stop with resistant, yes. So, fast movement, equal amplitude, no. This will be the answer. Okay. So, what is the difference between the jitteriness and the seizure? In the seizure, there will be autonomic involvement with eye movement, gaze eye movement is there. Along with there is a fast and slow component of the seizure activities. Okay. So, fast and slow component, but in jitteriness is a rhythmic and equal rate and amplitude, and there will be a movement is stimulus sensitive and movement cessation by flexion. So, jitteriness is stimulus sensitive and rhythmic in equal rate and amplitude. So, that is why the seizure here fast movement equal amplitude, that it is the not the neonatal seizure, it is only jitteriness. Okay. Now, move to the next question. According to the latest NRP 2020, after how many minutes resuscitation to be stopped and family should be counseled? Okay. So, according to the NRP 20, after 20 minutes, so an answer is 20 minutes. Okay. So, what is the difference? That is the NRP, this is the 2015 and this is the 2020. So, umbilical cord management plan added a 4 birth questions. So, replacing the how many babies. So, here the now 4 pre-birth questions are: what is the gestational age, amniotic fluid is clear or not, additional risk factor is present or not, and umbilical cord management plan. Okay. So, how many babies is replaced with the umbilical cord management plan? So, this is the changes. Now, the next change is initial step recorded to better reflect common practice. So, initial step now is first warm followed by dry, stimulate, position airway, suction if needed. Previously, the initial step was warm, maintain normal temperature, position airway, clear secretions if needed, dry, stimulate. Instead of this, warm, dry, stimulate, position, suction. So, these are the nowadays. Now, next is the electronic cardiac monitoring is recommended earlier in algorithm. So, alternative airway becomes necessary, and when a cardiac monitor is recommended when for most accurate assessment of the baby's heart rate. Now, epinephrine IV or intraosseous flash volume increased. Previously, the flash volume was 0.5 to 1 ml, now it is 3 ml. Clear? Now, the dose of IV or intraosseous and endotracheal dose is nowadays for the initial dose, that is 0.0 to mg per kg or 0.2 ml, it is IV or intraosseous dose, but the endotracheal dose is something different, it is around 0.1 mg or equal to 1 ml per kg. Okay. So, this is the change. The expanded time frame for cessation of resuscitative efforts that I have discussed, that is around 20 minutes NRP should be discontinued. Okay. So, these are the changes of 2020. Now, next question. A vigorous baby was born with thick meconium stain liquor. What should be done? So, the child is vigorous. Okay. Vigorous and non-vigorous. Vigorous baby should be like the initial steps should be normal, like normal baby. Okay. So, what do you mean by vigorous baby? HRT, the heart rate more than 100, good respiratory effort and tone is good. So, if these 3 is present, that is vigorous baby. So, it go through the normal initial steps, that so there will be the answer will be oropharyngeal suction. Okay. Now, next. So, a 26 weeker like 500 and 750 gram preterm baby developed respiratory distress soon after birth and got settled by using CPAP. What is the time of postnatal ultrasonography? Usually in preterm you do the ultrasonography after 72 hours. In this case, the postnatal ultrasound should be done at day 1. Okay, so this is clearly written. Approximately half of the means on the day 1, 50%, half of the IVH occurs on day 1, day 2, 25%, and day 3, that is 15%. So, if the single scan on 3 to 4 day of life likely to detect 90% of all hemorrhage. That is why usually the USG is recommended on day 3. But if the birth weight is 500 to 750 gram, 2/3 of baby having IVH occur on day 1 and resemblance will perform first scan on day 1. So, first scan for this 500 to 750 grams baby should be done on day 1. The answer is day 1. Okay. Now, next, not a component of developmentally supportive care, family centered care, protected sleep, healing environment, early intervention therapy. So, here the answer is D, early intervention therapy. So, the component of developmentally supportive care, the mnemonic I have made, that is APH, antepartum hemorrhage for sleep, sleep for APH. What is this? Sleep means protracted sleep, for means family centered care, FCC, A means activities of daily living, P for pain and stress, and H for healing environment. So, sleep for APH, protracted sleep, family centered care, activities of daily living, assessment and management of pain and stress, and healing environment. So, APH, sleep for APH is a mnemonic. That is why family, yes, protected sleep, yes, healing environment. So, these the 3 are component of developmentally supportive care, except is the early intervention therapy. So, that is the answer. A newborn had normal serum ionized calcium, but low total serum calcium. So, what could be possible cause? So, the most possible cause is hypoalbuminemia. The total calcium is low, but ionized calcium is normal, total calcium is low. It is due to the hypoalbuminemia. Measurement of total serum calcium concentration alone can be misleading because the relationship between the total calcium and ionized calcium not always linear. With hypoalbuminemia, total serum calcium is low while ionized calcium is normal. Again, falsely low ionized calcium may be recorded with alkalosis and with heparin contamination. So, these are the 2 conditions where the falsely low ionized calcium is recorded. Okay. So, this is important. So, these 2 lines is very important. Now, moving to the next question. A neonate developed neonatal seizure. Investigation revealed serum calcium of 6.4. He was started on IV calcium gluconate at 80 mg per kg per day for 2 days. Repeat serum calcium was 8.9. So, it is normal. What is the next step? Stop IV calcium, continue IV calcium, stop IV calcium and give oral calcium at 40 mg per kg, stop IV calcium and give oral calcium 80 mg per kg. So, symptomatic hypocalcemic seizure. So, what is the guideline? The guideline is the hypocalcemia with symptoms, you continue IV calcium gluconate 2 ml per kg bolus followed by 80 mg per kg per day for 48 hours and shift to the document normal serum calcium is documented and reduced 40 mg per kg for 24 hours, it may be oral and then stop. So, 2 ml per kg bolus followed by 80 mg per kg per day 48 hours. If normal calcium, then reduce 40 mg per kg for 24 hours, it may be rolled. So, the answer will be C. Okay, give oral calcium. Now, which of the drug used during induction phase can produce peripheral neuropathy? So, induction phase of ALL. Okay, so leading to peripheral neuropathy. The answer will be D. The vincristine leads to peripheral neuropathy. Now, these are the common drugs. Their side effects is asked in previous exam. So, methotrexate Side effect is hepatitis, myelosuppression, mucositis, dermatitis, okay, and arachnoiditis, leukoencephalopathy, leukomyelopathy, okay. The 6 mark of tryptophan, there will be hepatic necrosis, cytarabine or aracy, there will be arachnoiditis, mucositis, cyclophosphamide. So, this is very, very important. This leads to hemorrhagic cystitis, SIDs, pulmonary fibrosis, infertility and bladder cancer. Okay. And this hemorrhagic cystitis can be prevented with Meshna. So, this was asked in previous exam. So, SIDs is a side effect of cyclophosphamide also. Now, adriamycin or doxorubicin, the red urine and conjunctivitis along with cardiomyopathy. Okay, red urine, doxorubicin and dexamethasone reduces the risk of cardiotoxicity. Okay, dactinomycin, it is a radiosensitizer. Bleomycin, other than pulmonary fibrosis, Raynaud's phenomenon. And vincristine, there will be peripheral neuropathy, constipation, Elias, Chopin, SIDs. So, SID is a side effect of also cyclophosphamide and vincristine. Okay. And vinblastine, local cellulitis, leukopenia, pancreatitis is a side effect aspergillus. Other than this, P for pancreatitis, P for platelet dysfunction and coagulopathy also side effect of aspergillus. Now, the pulmonary fibrosis is side effect of carbamazepine and prednisolone, the steroid side effect is avascular necrosis, commonly asked questions, and cisplatin side effects are tetany, HUS, other than renal and ototoxicity. Etoposide. So, another important side effect, that is secondary leukemia. Okay. And the tretinoin, dry mouth, hair loss and pseudotumor cerebri. So, these are the common side effect of anti-cancer drugs. Moving to next, not an indication for initiation of therapeutic hypothermia. So, duration more than 9 hours? No. Moderate to severe? Yes. Outside status and seizure at admission. So, these are the important. So, here the indications are cooling should be started within 4 to 6 hours, not after 9 hours. So, conditions of therapeutic hypothermia. Therapeutic hypothermia is a common topic and there are many questions asked in INI and NEET-SS also. So, here the indication are moderate therapeutic hypothermia, that degree is, that is 33 to 34. This was asked in question. And initiated within 4 to 6 hours, yes, continued for 72 hours and infants of at least 35 weeks of gestation, that is more than 2 kg with moderate to severe. So, initiated should within 4 to 6 hours, continued for 72 hours, which babies 35 weeks or more than 2 kg, okay, and the temperature is 33 to 34 degree. So, here from here the answer will be A. Okay. Here the types of therapeutic hypothermia: selective cooling of the head and whole body cooling. Now, what is the mechanism of action? It decreases cerebral metabolism and flow, leads to the decrease in energy requirement of cerebral edema. Decreased brain lactic acid, glutamine and nitric oxide concentration leads to less excitotoxic and oxidative injury. Inhibits protease activations, mitochondrial failure and free radical damage, lipid peroxidation. There will be less apoptosis and necrosis. So, what is the contraindication of therapeutic hypothermia? If there is severe congenital anomaly and if there is suspected lethal chromosomal abnormality like trisomy 13 and 18 and clinical and echocardiographic evidence of PPHN, active bleeding, catecholamine resistant shock and major intracranial hemorrhage. Okay. Now, coming to the adverse effects, sinus bradycardia and thrombocytopenia is the common adverse effect of the therapeutic hypothermia. Okay. So, moving to the next, and here the selection criteria of neonatal therapeutic hypothermia, the newborn, inborn and outborn is different. So, age of presentation both are less than 6 hours and the outborn, any one of the following is required: absence of cry at 5 minutes and need for IPPV, positive pressure ventilation, till 5 minutes of birth is the important criteria for the evidence of birth asphyxia in outborn. So, the in this topic, the question outside status also depends. Therapeutic hypothermia, it depends on the outside status of the newborn. Okay. Now, this is the assertion and reason type. Regarding therapeutic hypothermia, the assertion is it decreases energy requirement and cerebral edema and cerebral blood flow, and the reason is it decreases lactic acid, glutamic, nitric oxide concentration and inhibit protease activations. So, here assertion and reason are true, and reason is correct explanation of assertion. No, assertion and reason is true and the reason is not correct explanation of assertion. So, see the assertion here, decrease energy requirement and cerebral edema and cerebral blood flow. Here the decrease in energy requirement and cerebral edema. So, due to decrease cerebral metabolism and blood flow. So, blood flow and metabolism decrease, that is why there will be decrease in energy requirement. So, and the reason here that it decreases lactic acid and glutamine. Decreases lactic acid glutamine leads to less excitotoxic and oxidative injury. So, assertion and reason is true, but is not the correct explanation of the assertion. This is the answer. Okay. Now, moving to the next, not a component of PIPP, that is premature infant pain profile. So, this is a topic repeatedly asked question. So, not a component of PIP, duration of cry, gestation, behavioral state, heart rate. So, what is the answer? It will be the duration of cry. So, I have made the mnemonic good boss. So, what is this? Good boss. Good means parameter of gestation, B for behavioral state before procedures, O for observe the infant for 30 seconds after procedure, and SO2 and heart rate. So, here good, G means gestation, boss, B behavioral state, or there is not heart rate. So, these are the three parameters. Now, duration of cry is not a parameter of PIPP. Okay. Another new question, that is what is IKMC stand for? What is IKMC? IKMC means it is immediate KMC. Okay. Immediate KMC. IKMC means immediate KMC. Immediate kangaroo mother care. What is this? KMC is usually initiated 3 to 4 days after birth, which means that the large number of deaths among preterm babies have already occurred. The IKMC trial in the aims to assertion of initiating immediate KMC after birth is an additional benefit for survival. So, IKMC, that is immediate KMC, have the benefits for survival of the preterm baby. So, IKMC preferred. Okay. So, the trial was conducted in 5 tertiary levels hospitals: Ghana, India, Malawi, Nigeria and Tanzania. Okay. So, these are the immediate KMC. IKMC means immediate KMC. This is a new one. Now, move to next question. A 7-day-old neonate with excessive crying, progressive difficulty in feeding and reduced movement of limbs. What is the diagnosis? Excessive crying on day 7, progressive difficulty, reduced movement. So, it is most likely tetanus. Okay. Day 7 means the usually presents in between, the typically manifested in 3 to 12 days, mostly roughly around day 8. It presents as progressive difficulty in feeding, sucking and swallowing, and associated with hunger and crying. So, this is the important point. And the paralysis or diminished movement, stiffness and rigidity to touch and spasm with or without opisthenosis are characteristics. So, paralysis or diminished movement, stiffness, rigidity to the touch and spasms with or without opisthenosis are characteristics of tetanus. Moving to next. So, this is very important. Antenatal USG depicts unilateral hydronephrosis. Now, postnatal USG on day 3 showing right-sided hydronephrosis with dilation of ureter. The SFU grade is 3. What will be the next step? So, here according to this options, the B will be the answer, because MCU at 3 to 4 weeks, if B are present, give antibiotic prophylaxis. So, answer will be B. But usually the flow chart in the AIMS flow chart, suppose if there is antenatal hydronephrosis, then perform postnatal ultrasound within 24 to 48 hours after birth. If there is LUTO, that is lower urinary tract obstruction, is suspected, but in 2 to 7 days before discharge in other cases. Okay. Now, if there is no hydronephrosis and SFU grade 0 and anteroposterior diameter less than 7, then USG at 4 to 6 weeks is recommended. So, this is the question given in AIIMS. APD is less than 7. Now, if the unilateral or bilateral hydronephrosis and lower urinary tract outflow unlikely, so if there is SFU grade 1 and 2 and APD less than anteroposterior diameter less than 10, then USG monitoring 4 to 6 weeks. Now, if the SFU grade is 3 and 4 or APD anteroposterior diameter is more than 10, then MCU at 4 to 6 weeks. So, these 3 questions is very important: less than 7, less than 10, more than 10. Okay. Less than 10, 4 to 6 week USG monitoring, but more than 10, MCU at 4 to 6 weeks. So, here the 4 to 6 means 4 week is there, that is why the answer is B. Okay. Now, moving to the next question. 3-year-old boy with limp of hip joint and pain, not associated with fever. History of respiratory illness 2 weeks back. Counts and CRP ESR is normal. USG suggestive of mild intra-articular collection. What is the treatment? So, what is the diagnosis? It is transient, because there is a history of there is a previous history of respiratory tract infections, but the CRP and ESR is normal. USG is mild intra-articular collection. So, the diagnosis is transient synovitis. Okay. So, the transient synovitis of hip, it is the most common cause of hip pain and limp in children 10 years of age. The transient synovitis hip is also known as observation hip, toxic synovitis or irritable hip. It is self-limiting, only a short time, therefore known as transient. Cause is not known, but associated with the upper respiratory tract infection, and in this case there is a upper respiratory tract infection. The child may have low grade fever, ESR, CRP and WBC count are normal. Okay. So, this differentiates transient synovitis from septic arthritis, where ESR and CRP is increased and WBC also increased. The USG, there will be ultrasonography may show widening of the joint space, and the treatment is bed rest and NSAIDs and observation. So, the answer will be NSAIDs, oral NSAIDs. So, this is